Hi, thank you for joining us during this ecancertv program. We are in Milano during the meeting of the European Hematology Association. And my name is Prof Moreau. I'm working in Nantes in France, and I'm joined today by Prof Mateos, working in Salamanca in Spain. And I wanted to ask you, Marivi, about the treatment of elderly patients. The landscape is changing very, very quickly, and we are thinking that maybe in the future alkylators will be dead, and we probably don't need to use melphalan. That was the standard of care, at least in combination with thalidomide or with bortezomib. So what is your opinion? And you presented updated data on the Spanish study.
Yeah, you are right, because the role of the alkylator as part of the treatment of elderly myeloma patients is now in debate, because melphalan wanted to be abandoned. And in line with this, in 2005, you know that the Spanish myeloma group activated a trial to try to answer this question: which is the best partner for bortezomib, alkylator, melphalan, or thalidomide as immunomodulatory drug? And in fact, when we published the results of this trial in 2010, 4 years ago, our conclusion was that VMP seems to be superior to VTP, because considering efficacy and toxicity, PFS and overall survival, there was a trend to better outcome for patients receiving VMP. So as the role of melphalan is a key debate at the present time, we decided to update this trial, and this is what I have presented here during this Congress.
What was the follow-up?
The follow-up is 6 years.
6 years.
So I think that it's a longer follow-up in which we have confirmed that VMP is superior to VTP as induction for elderly patients with multiple myeloma. Median progression-free survival for patients receiving VMP was 32 months, and median overall survival of 60 months. But I think that the most interesting data is that patients achieving complete remission, and especially in immunophenotypic complete remission, achieved significantly longer progression-free survival and overall survival, indicating that probably VMP induces more profound responses as compared with VTP.
So you have confirmed, Marivi, that the response rate is higher with the VMP combination. But into that study, you had also a maintenance phase that could also explain partly the very impressive results in terms of overall survival. So do you think that we should try to use systematically a maintenance? You use bortezomib and thalidomide in this specific study.
I think that it's a good question. At the present time, we don't use maintenance outside of clinical trials, but I think that the future for all elderly and probably also young newly diagnosed myeloma patients will be the continuous therapy, so the prolongation of the therapy, because you're right, in our trial, after 6 induction cycles, patients received maintenance with bortezomib plus thalidomide or bortezomib plus prednisone, and probably the role of maintenance is influencing in the long outcome observed in our study. But anyway, when we compared VMP with VTP, VMP was superior regardless of the maintenance therapy.
This is important to know.
Yeah. And so, concerning your study conducted with bortezomib given in a subcutaneous route, I think that an important question is if can we use confidently subcutaneous bortezomib in patients with renal impairment?
That was a very important question. In fact, we are using now sub-Q in routine. Let's say we did a survey in Europe, almost 85% of the patients are receiving bortezomib sub-Q, not only at the time of the relapse, but also as part of frontline treatment. And we were not that sure that the sub-Q administration was as effective as the IV one in patients with renal impairment. And we know that not only at the time of diagnosis, but also and mostly in the relapse setting, we do have the renal impairment issue. So we did a sub-analysis of the phase 3 study, pivotal study for the approval of sub-Q, And we looked at a subgroup of patients with a renal impairment with a creatinine clearance less than 50 milliliter per minute. And then there were 46 patients. And we did compare these patients with those without renal impairment. And some of them received IV, some of them received sub-Q. And we showed that with the sub-Q, the time to response in patients with renal impairment was shorter, 2 months versus 3 months. And also the response rate was slightly higher with sub-Q in the patients with renal impairment as compared with IV. Overall, no difference in terms of overall survival. So we can conclude very easily that we are not doing any mistake with the sub-Q administration in patients with renal impairment.
And concerning the renal response?
Concerning the renal response, we had the number of patients that we were able to have an improvement in the renal response was similar, in fact, when comparing sub-Q and IV.
So I think that your results are very interesting because even unexpected results, because many people are against the use of sub-Q in patients with renal impairment, and your results consolidated that we can use sub-Q bortezomib in all patients without any problem. Exactly, that's quite important in the routine practice now that we have moved almost all of us with the sub-Q administration of the drug. It's an important message for the community. Thank you. So thank you, Marivi, for speaking with me today, and I hope you were also happy to have this discussion. Yeah, thank you very much. It has been also a pleasure for me. Thank you.